So today we are going to talk about the lung cancer and mediastinal staging. So lung cancer is one of the commonest cancer which happen all over the world, and it can be non-squamous lung cancer, non-small cell lung cancer, and small cell lung cancer. The non-small cell lung cancer accounts for 85% of all the lung cancer, and we need to take the biopsy for the identification and molecular characterization and for accurate classification into various subgroups. And now the mutation-specific targeted therapies are available, which are more effective. The mediastinal staging, therefore, plays a very important role for appropriate management and for finding the prognosis of the patient with a cancer. So there are several treatment modalities for diagnosis and management, and they can be grouped into the standard surgical approaches and the minimally invasive approaches. The approaches include the clinical staging determined by the CT or a PET scanning, and if the lymph nodes are enlarged more than 1 centimeter in the short axis or in the PET avid nodes who have the SUV value of 2.5 are considered to be potential targets. The N1 nodes are considered to be ipsilateral hilar, peribronchial and intrapulmonary, and N2 nodes are ipsilateral mediastinal and subcarinal, and N3 nodes are contralateral mediastinal or supraclavicular lymph nodes. The invasive mediastinal staging is often used in N2 and N3 disease, and the induction therapy can be offered or a definitive dose radiation therapy or in addition to a surgical resection may be appropriate. In the case of metastatic disease at any point during the evaluation, there is no further need for mediastinum as the patient with advanced disease are not considered as a surgical candidate and they are offered the systemic therapy likely. The lymph node metastasis is low for CT1A N0 M0 disease, such that the preoperative tissue biopsy is typically unnecessary and surgical resection and intraoperative lymph node evaluation, sampling or dissection is sufficient. So the lymph node is stationed in the supraclavicular zone. Biopsy of the lymph node is important rather than mediastinum. In superior mediastinum, there is midline defined by the left lateral border of the trachea, and azygous vein differentiate R4 from 10R. And in the aortic region, it's important for suspected left upper lobe lesion, and the nodes are 5 and 6. And in the inferior mediastinal region, transesophageal and pulmonary ligament nodes can be assessed by endoscopic ultrasound. In the case of N1 nodes, they are in double digits, and station 10 nodes are located along the main stem bronchi, and the hilar vessels versus station 11 nodes are located between the origin of the lobar bronchi. So minimally invasive techniques are important, and the goal of mediastinal tissue evaluation is to provide the histopathological diagnosis and to designate accurate disease while obtaining sufficient material for molecular characterization. In general, the minimal invasive technique utilizes the endoscopic ultrasound with a fine needle aspiration, core needle biopsy, and the selected approach should be used on the basis of ability to assess the targeted site and the suspicious lymph nodes are staged. Endobronchial ultrasound and transbronchial needle aspiration has emerged as an important step in diagnosis of this disease, and it has a good sensitivity and specificity, and the lymph nodes which can be assessed include 2, 4, 7, 10, 11, and 12. The tissue samples are collected via multiple needle passes, where a good opposition balloon probe at a distal tip of bronchoscope is critical for adequate visualization of the lymph node targets as well as nearby vessels bordering the airway. So it has attained a gold standard in the recent years, and the limitation include the operator variability and inability to assess peri-aortic, paraesophageal, and pulmonary ligament lymph nodes. Transesophageal endoscopic ultrasound is fine needle aspiration, and it was originally designed for gastric and esophageal cancer but has adopted for lung cancer staging as well. The transesophageal endoscopic ultrasound can be used for paraesophageal and pulmonary ligament lymph nodes, and it has a good predictive value. The other technique which can be used are transthoracic needle aspiration, conventional bronchoscopy, and navigational bronchoscopy, which is important for the targeted peripheral lesions. There are various surgical approaches which can be used, and they have different advantages and disadvantages, and we'll discuss these in detail. The cervical mediastinoscopy is considered as a gold standard for staging with a higher sensitivity and negative predictive value, and we can directly see the target lymph node, and we can take out a good specimen, and usually given incision in the pretracheal lesion, and gradually we approach towards 2, 4, 7, and 10 lymph nodes. VATs provide a direct visualization, and we can take the N2 nodes and N1 nodes biopsy, and in early stages they can be wedged out, and or the tumor could be taken out as segmentectomy or lobectomy. Chamberlain procedure is classically the left anterior mediastinoscopy with parasternal incision in the second left intercostal space, and it can be used to assess lymph nodes station 5 and 6 and the risk of injury to the lima and phrenic nerve is there. There are various other additional approaches that can be used, but in summary, with the EBUS we can access to the higher group of lymph nodes 2, 4, 7, 10, 11, and 12 with esophageal ultrasound 2, 4, 7, 8, and 9, and cervical mediastinoscopy 2, 4, 7, 10, Chamberlain procedure 5 and 6, and with VATs on the right side 4, 7, 9, and 1, and left side 5, 6, 7, 8, 9, and 1. So this is a very important consideration, and we have to apply different approaches depending on the patient's need. I hope you enjoyed it. Thank you very much.